Good day, future RMTs. Welcome to our discussion. And in this video, what we are going to discuss is all about laboratory markers of cardiac damage and function. Our learning outcomes are as follows. Number one is to recall the functions of the heart and, of course, to interpret laboratory results to determine abnormalities in the cardiac function. To start with, let us remember first, or let us recall the anatomy and physiology of our heart. We all know that cardiovascular system, now particularly the heart, plays a vital role in our body as this pumps the blood throughout the circulation. Heart is a hollow muscular organ, which is typically 325 grams, typically 325 grams in male and 275 grams for female. Our heart is located in the middle section of the chest cavity with, between the two lobes of each lungs and slightly positioned to the left of the sternum. That's why they are always saying that the heart is located at the left side of the lungs. But a little as they know, heart is positioned no, within the center of our pericardial cavity. It just so happened that majority of the portion of the heart is slightly uh, uh, towards to the left of the sternum. Okay, the heart is enclosed with what we call pericardium, and this pericardium, no, the pericardium, okay, pericardium is a double layer fibrous muscle that covers the heart, and the inner layer is what we call the visceral, no? The inner layer of the pericardium or the visceral, and the outer layer is the perineal. And it is separated by what we call pericardial fluid. Okay? So again, the layers of the heart are number one, the outer layer. No? The outer layer is the epicardium. Okay? Where is it? Here. Okay? The epicardium is the outer layer. The next layer is the myocardium, which is considered as the middle layer. And lastly, we have your endocardium, which is the inner layer of the heart. If we are going to discuss the anatomy or the physiology of or the anatomy of the heart, rather, there are four uh, chambers of the heart, namely as the right atrium, the right ventricle, the left atrium, and the left ventricle. Okay? Take note, guys, that this right pump, the right atrium, and the right ventricle, okay, is composed of the tricuspid valve, the pulmonary valve, and the pulmonary artery. Remember that this right valve, no, or the right atrium, receives the blood from the circulation. Okay, receives the blood from the circulation, and then take note that this blood that received, that this blood that was that enters into the right atrium is oxygen poor blood. Okay, the oxygen poor blood will enter into the right ventricle, right atrium. Okay, and then stored it on the right atrium until it will be, or the heart will do contraction. Okay, so after that, it will pass through what we call tricuspid valve. Okay, and then going to the right ventricle, going to our pulmonary artery. Okay, and this going to the pulmonary artery delivers the blood to the lungs so that the lungs will oxygenize, so that the blood will undergo what we call oxygenation. Okay, again, the right pump. Now this is our right pump, the right atrium, the right ventricle, and the pulmonary uh, valve, as well as the pulmonary vein. The oxygen poor rich blood will enter the right atrium, and the blood will store in the right atrium until contraction that will pass through the tricuspid valve, going to the right ventricle. The oxygen-poor blood will pass through our pulmonary valve, going to the pulmonary artery, so that it will go to the lungs for the lungs to oxygenation, no? For the oxygenation process. Okay. Now, after the oxygenation of the blood in the lungs, it will enter into our left atrium, no? Left atrium, yeah, that's correct. Left atrium. Now, this time, the blood that will enter into our left atrium is oxygen-rich blood that came from the lungs that will pass through our left ventricle going to our aorta. Take note that this aortic valve allows the blood to enter aorta to circulate going back to the circulation or going back throughout the body. Okay, that's why in cases of contract or heart contraction or abnormality in the heart contraction, there will also be deficiency in the oxygen, the amount of oxygen and the amount of blood because hindi natutuloy or there is a abnormality no, in the pumping of the blood or the flow of the blood in our heart. Now, remember guys that cardiovascular disease is one of the most commonly significant diseases associated to man. Okay, and cardiovascular disease can be classified into four categories. We have number one, coronary heart disease. Number two is we have cerebrovascular disease. Number three is we have peripheral arterial disease. And lastly, we have aortic atherosclerotic disease. What do we mean by coronary heart disease? Take note, guys, that coronary heart disease, or also known as the CHD, no, myocardial infarction is commonly referred as a heart attack, which is evident to the patient who are experiencing coronary heart disease. Now, even though or aside from myocardial infarction, there are other evident symptoms that is experienced by a patient with coronary heart disease, and those are angina pectoris, which is commonly known as the chest pain. We also have heart failure and sudden cardiac death, no, are also experienced by a patient with coronary heart disease. However, myocardial infarction is the most common, no, which is referred as the heart attack. As per cerebrovascular disease from the word itself, cerebro, which means there's an involvement no, of the uh, cerebrum or the brain. Take note, guys, that cerebrovascular disease okay, manifests stroke or transient, transient ischemic attack, which is considered as reversible stroke. Okay, transient nawawala, ischemic no problem in the amount of the blood. Okay, why it leads into what we call stroke. Okay, yun yung sinasabi minsan na naubusan ng hangin ang um, ang brain. Okay? Next is we have your peripheral arterial disease. Take note that peripheral arterial disease manifests intermittent claudation. And what do we mean by claudation? Claudication pala, I'm sorry. Claudication. What do we mean by claudication? Claudication is a localized pain in the arms and legs of a patient who are experiencing cardiovascular disease. And lastly, we have your aortic atherosclerotic disease, no, and aneurysm. Okay? Aneurysm is common to a patient who had aortic atherosclerotic disease. And as we said, what do we mean by aneurysm? Aneurysm is defined as abnormal widening of the artery. There are 7 classical symptoms of cardiovascular disease, which I want you to take note. Number 1, we have what we call dyspnea. Okay? What do we mean by dyspnea? When we said dyspnea, that is a cardiac and cardiac, pulmonary, and psychological. Okay? Yun yung mga dahilan kung bakit nagka-experience ng dyspnea. The other classical symptoms of a cardiovascular disease is chest pain. As said a while ago, no? Uh, as said a while ago, we have your angina pectoris. No, this is a gripping, crushing pain. No, uh, within the chest. No? And sometimes the pain in the chest radiates to the neck, jaw, and in one arm. Usually or commonly yung left arm. The third symptom is palpitation. Okay, pumping, skipping of the heartbeat. You also have the synop, no, abnormal rhythm, no, commonly arrhythmia. Next is we have edema. Okay, edema, as we all know, is the accumulation of fluid. Take note that in uh, congested heart disease, the heart is congested with too much fluid. That's why the heart cannot pump. Okay. Next, we have your cyanosis. Okay. And lastly, we have fatigue. Okay. So these are the 7 classical symptoms of cardiovascular disease: dyspnea, chest pain, palpitation, synop, edema, cyanosis, and fatigue. However, aside from that, we also have what we call atherosclerosis. Okay? What do we mean by atherosclerosis? No? Take note, guys, that atherosclerosis is defined as the chronic process involving damage to the endothelium and buildup of cholesterol-rich lesions. That's why if you still remember in our discussion in lipid, no, and lipoproteins, we said there or we agreed there that those patients who are having problems in the metabolism of the lipids can have or most probably could develop a heart disease. And because of the deposition of the lipids in the circulation, that leads into what we call narrowing of the blood vessel. Okay. Now take note, guys, that if a patient had or has an atherosclerosis, it increases the possibility of ischemia, which then for lack of blood supply. Now, it is important for us to differentiate acute coronary syndrome from non-acute coronary syndrome. Okay, mahalaga yun. Mahalaga we know that what is the difference between acute coronary syndrome and non-acute coronary syndrome. Because the signs and symptoms experienced by a patient with acute coronary syndrome can be also experienced by those person with non-acute or non-ACS. Let's say for example, heartburn. Yung heartburn, nagsisikip din yung dibdib mo. But it doesn't mean that is a cardiac arrest or involves the cardiac because of the hyperacidity. All right. Now, remember what we have is we have what we call cardiac ischemia. Take note that cardiac ischemia can lead into what we call chest pain. Okay, can lead into what we call chest pain. And again, this chest pain can be classified as your stable angina. Okay, stable angina or you have your acute coronary syndrome. Now take note, guys, when we said stable angina, okay, when we said stable angina, okay, this is due to the activity. And if you had your rest, if you have your rest, it will resolve. However, okay, however, when we said acute coronary syndrome, the cardiac arrhythmia can be due to ischemia, due to chest pain, stable angina, or ACS, due to coronary heart or acute coronary syndrome. If the chest pain or if the chest pain is associated to acute coronary syndrome or ACS, thus therefore it is considered as unstable angina. Okay? Remember, guys, that ACS is unpredictable. Okay? It's unpredictable. Hindi mo naman alam kung kailan ka atakahin sa puso. Acute coronary syndrome can also be in the form of severe acute myocardial infarction. Okay? Remember, in unstable angina, the cardiac markers are normal. But in cases of severe acute myocardial infarction or even myocardial infarction, our laboratory markers for cardiac function and cardiac damage are increased. Okay, again, when you said angina, no, that is squeezing of the chest, heavy chest pressure, burning feeling, and the burning feeling that can lead into what we call difficulty in breathing. Okay, take note that this pain or that these signs and symptoms or signs or these classic signs, no, classic signs as what we said. Okay, these classic signs can radiates to the left shoulder, neck, and arm. However, there are other non-classic symptoms. No? Non-classic symptoms. What are those? Number one, we have your stabbing. Number two, we have your pulsating. And number three, we have your sharp chest pain. Okay? And these non-classic symptoms is usually experienced by women. Okay? Signs and symptoms or symptoms not related to cardiac arrhythmias or induced angina. Ito po yung mga yun. Take note. We have what we call pleuritic pain. No, a sharp knife-like pain brought by respiratory movements or cough. Di pa kita sakit yan, sabihin mo agad meron ka ng unstable angina due to coronary heart syndrome. Okay? Epigastric pain, primary solely location of the abdomen. A pain that localized in the tip of the finger, particularly over the apex of the heart. No? Pain reproducible by movement, palpitation of the arms or chest wall. Constant pain that lasts for many hours. Very brief episodic pain for a few seconds or less. Pain radiating to the lower extremities. Indigestion. Increasing dyspnea in the absence of chest pain. Psychiatric disorders such as somatoform disorders, panic disorders or panic attacks, and anxiety disorders. Severe non-cardiac conditions such as sepsis, no, burns, respiratory failure, neurological diseases, and drug toxicities. Take note that the symptoms are not related to cardiac ischemia-induced angina, but there is a possibility that these symptoms, that these cases can cause chest pain, but not necessarily mean they are related to cardiac ischemia. Now, according to American College of Cardiology and American Heart Association, they classified no, uh, cardiac problem into two, class 2B no, and class 1. Okay? Kapag class 1 suspected of acute coronary syndrome, and this is a patient no, with high-risk features, which include chest pain, synop, no, temporary loss of consciousness. Okay? Why? Bakit nagkaroon ng temporary loss of consciousness? Because of insufficient blood flow to the brain. Palpitation is also experienced by a patient with class 1 ACS. And if a patient experiences those symptoms, no, he or she must be immediately transported to the hospital for further evaluation of cardiac markers. Okay? While for type 2B, these are non-common or less severe symptoms. However, no, the patient must undergo physical examination, okay, which includes the blood pressure, no, the pulmonary disease or heart failure. Tingnan natin. And aside from that, we have to perform ECG, electrocardiogram. Electrocardiogram. Let's check if his or her ECG is correct. for the rhythm, the beat of the heart. I have here the normal pattern of our ECG. Excuse me. So we have there your P, Q, R, S, T. Okay. This is the PR interval, not PR interval. This one is the PR segment. This up to this one is what we call Q R S segment. Okay. This is the S, the end of S, start of T, the ST segment, and this is our the start of Q and the end of T is what we call the QT interval. So Q. Now, ano na din? Okay. Now, I have here an example of a result of an ECG. One is normal and the other one is subnormal. Now, which do you think is normal? Yung nasa taas or yung nasa baba? Kung ang pinili mo ay yung nasa baba, patay tayo dyan. Okay? Kung ang pinili mo ay yung nasa baba, patay tayo dyan. Because the normal one is on the taas. Okay? So take note, ha? The PR interval, okay? The QRS complex and the QT interval should be like this. Okay? If you will take a look with this one, and if you are going to take a look with this one, hindi po maganda yung rhythm. Referring to the normal rhythm, which is like this. Yeah. And looking at this one, what can we observe? There is a long ST segment. No? This one, ST segment. Thus, therefore, it is an indication of acute ischemia. The change in ST segment more than 1 millimeter is an example or is correlated to what we call acute ischemia. And take note that abnormalities in the T wave, such as like this, okay, is an indication or will be helpful to detect or to know that there is an abnormality in the rhythm. I'm going to give you or share with you a short audiovisual presentation more about ECG.
The cardiac conduction system consists of the following components. The sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram ECG or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires, electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction or atrial systole starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation or ventricular diastole. The cycle repeats itself with every heartbeat.
Okay, so the next video that I'm going to share to you are the normal, or yes, is audiovisual presentation, okay, of the heartbeats, no, from the normal heartbeat or normal heart sound until different no conditions. Okay, so those are the sound of the heartbeat. This time, let's discuss the pathophysiology of atherosclerosis. Again, take note, guys, when we said atherosclerosis, this is a chronic disease no, that can be found in human aorta at the age of 10. No? Progressive accumulation of the lipids, smooth muscle cells, macrophages, and connective tissues within the large and medium-sized arteries is atherosclerosis. As you can see here in the illustration that I have here on the screen, no, this one connotes or denotes the lipids, no, the accumulation of lipids in the smooth muscle. Take note, guys, that the ApoB lipoprotein, no, the ApoB100, pag mataas po yun, as well as our LDL, no, you are at risk of developing a heart disease. Okay, there's also what we call a hypothesis, no, because the exact etiology of atherosclerosis is unclear, because atherosclerosis is associated to a patient with what you call this lipid disorders, and the same time to a patient with glucose disorder. And we have what we call the atherosclerotic plaque, which is the erythemas. Okay. All right. And since the purpose of our today's discussion is to discuss the markers for cardiac damage, here are the most commonly cardiac markers, no, to to assess the cardiac damage. Number one, we have enzymes such as AST, LDH, and CK. As we all know, these enzymes are what we call cardiac enzymes, which are all important or which are all helpful in the analysis of our cardiac damage. Remember, guys, that the serum biomarkers have become the centerpiece of the evaluation and the management of patients with chest pain even before, most especially the activity of transaminase, which includes your SGOT, that's the former name, the serum glutamic oxalate uh, transaminase, and now referred as the aspartate transaminase. Okay, this was the method of assessing the SGOT or the AST was proposed by Ledoux et al. Okay, as we all know, activity of AST is not only confined in the heart. Meron din siyang activity in the muscle, activity in the liver. Okay? AST and SGOT or AST or SGOT was the first cardiac marker, okay, including uh, dehydrogenase, the lactic dehydrogenase. However, there's a word however, LDH is much more sensitive than AST. Okay? Much more sensitive than AST, okay? Based on their studies. Because AST nga will also have a activity in the muscle. That's why if you have a muscle injury, mataas din. And it does not necessarily mean there is a cardiac problem. However, LDH has 5 isoenzymes. Diba? LD1, LD2, LD3, LD4. Particularly the LD1, which has a high affinity or high activity in the heart. That's why if we have what we call the flip pattern, wherein LD1 is greater than LD2, then that is an indicative of cardiac damage. But researchers and studies shown that LDH cannot be used alone as a cardiac markers for uh, for this condition. Why? Because it can also be associated or it has also an activity with the red cells. Thus, therefore, it can be associated to cancer. Okay? Yun yung isang dahilan. AST will be the first non-specific enzyme to increase. Sunod the LDA. The non-specific. Non-specific. And one thing, LDH has the highest elevation time as compared to AST. And aside from that, the use of creatine kinase, and creatine kinase has dimers, M and B, and the isoenzymes MM, BB, and MB. No? M, the dimer M, activities on the muscle. B is the activities on the brain. Okay, so this is more on the muscle, more on the brain, and MB, the combination of dimer M and B, no, has an activity or highest activity in the heart. That's why elevated amounts or concentration of CKMB is associated to cardiac damage. This is the if we are going to compare, if we are going to compare the levels of CK, LDH, and AST in cases of cardiac problem, CK will elevate or rise at 4 to 8 hours after the attack. SGOT 6 to 8 hours. And LDH is 12 to 24 hours. Okay? Aside from that, we have troponins. Troponins are complex of 3 proteins. Take note that troponins are responsible for transmitting calcium signal that triggers muscle contraction. And we have what we call the troponin P, the troponin I, and the troponin C. What do we mean by T? When we said troponin T, that is referring to tropomyosin. Okay? Tropomyosin. How about I? I stands for inhibitory. Inhibitory. And C stands for calcium binding component. Okay? Take note, guys, the troponins have, uh, no. The troponins found to have a specific isoforms, no, versus skeletal and cardiac. And these isoforms are your troponin T and troponin I. Okay? CK is the first enzyme to increase, to be followed by AST, to be followed by LDH. And if we are going to use troponin T or troponin I as compared to these three cardiac markers, troponin I is much more advantageous than your CK, than your LDH, and than your AST. Why? Because it has the highest, or it will increase, no, in 3 hours after the cardiac arrest. Let's say, for example, troponin T. Troponin T will increase 3 to 4 hours. Troponin I 3 to 6 hours. No, mas mabilis tataas ang ating troponin T and troponin I as compared to CK, LDH, and AST. Actually, no, AST and LDH is not that useful na anymore. Usually, the cardiac markers used are troponin T, troponin I, and CKMB. Okay? Take note. That's the current biomarkers for myocardial necrosis. Troponin I and troponin T next to our CK. Eh bakit next to CK? Maganda rin si CK. Why? Because CK, no, elevation in CK means, no, problem or destruction in the tissue within the heart. Moving forward, I know that you are all familiar with this one. We've been using this table since then. Okay? So these are your cardiac markers. Again, we have your myoglobin. Myoglobin is the best protein cardiac marker. Although, lahat naman to protein eh. Protein to, troponin, CK, AST, LDH, there are proteins. Diba? Enzymes are proteins. But why myoglobin is referred to be best cardiac marker? Because it will rise 1 to 3 hours. Okay? Si CK, bakit siya yung useful na enzyme? Mabilis siyang tataas and siya yung mayroong pinakamatagal na stabilization. Stabilize within 72 hours, within 3 days. No? Si LDH, siya yung pinakamatagal, 14 days, sir. Yeah, but there are cases that LDH are also increased aside from heart problem. Nephrotic, di ba? Pulmonary, cancer, leukemia, anemia. Kaya nga sabi natin, LDH is a hematopoietic marker. Using this graph, okay, we can see that this one is the myoglobin. It will increase dramatically. This one is your troponin I. This one is your troponin T. This is your CK. Si CK siya yung best enzyme marker. Pero siya yung pinakamabilis mag-down within 3 days. Okay? Now, CKMB, troponin I, and troponin T in kidney disease patients. Ano yung meron doon? Number one, prognosis in chronic kidney disease. Take note, that, guys, that increases in the troponin T and troponin I in patients with CKD with MI. No, so mataas ang troponin T, troponin I, no, sa mga pasyente na mayroong CKD. For dialysis patient, take note that troponin T, no, T and T. Yan. Troponin T is increased in dialysis patients with cardiovascular disease. And one of the effects of hemodialysis in our enzyme markers or in our cardiac markers, no, it alters the concentration of cardiac markers, particularly the CKMB, but it has no effect in our troponin I. There are other laboratory markers for our cardiac damage, such as myoglobin. Like what I've said a while ago, no, it is the most significant protein cardiac marker. Why? Because it is released when a muscle in the heart is damaged. Okay, and again, this damage, no, this increase in the damage can cause no the release of myoglobin. You also have your heart type fat acid binding protein. No, the activity of this cardiac marker is almost synonymous with myoglobin. However, it is much more sensitive than our myoglobin because abundant of its activity can be found in the heart. Unlike myoglobin, kasi si myoglobin, meron din siya sa muscle. We have your ischemia modified albumin. This is not actually a test, but rather a measure that occurs in the albumin in the presence of ischemia. And lastly, we have novel markers for plaque stability, such as your myeloperoxidase, C-reactive proteins, and we have also your myeloid-related protein. And of course, we have your PAPA or PAPPA. Now, there are other conditions that triggers no cardiac problem, such as your cardiomyopathy. Okay, we also have your compensated heart failure, volume overload, pre-heart failure state, myocarditis, infection in the heart, drugs, uh, and the others, no, that could lead into this condition. Now, what do we mean by cardio? Let me correct this one. Cardio. Okay. What do we mean by cardiomyopathy? Take note of this disease, no, of the heart muscle makes it harder for the heart to pump the blood. Okay, makes the muscles of the heart harder, okay, to pump the blood. Take note that cardiomyopathy can lead into what we call heart failure. Now, what's the difference between myocarditis from cardiomyopathy? Myocarditis is inflammation of the heart, okay? Inflammation of the heart due to bacterial infection. Let's say, for example, sepsis. Drugs, no, toxicity of the drugs can lead into a heart problem. Overdose of digoxin and the other conditions that can also trigger the heart, the function of the heart. Now, these are the sources of cardiac injury. Now, take note, guys, that cardiomyopathies can be due to dilated, hypertrophic, or stress-related that makes the heart, uh, that makes the tissue of the heart, no, difficult for them to pump the blood. Myocardial infarction, no, can also lead into cardiomyopathies. Ischemia is the common reason of myocardial infarction that can lead into cardiac injury. Cardiac hypertrophy, lumalaki, can lead into heart failure that can lead into cardiac injury. Viruses, no, or bacteria, no, can lead into what we call myocarditis or sepsis-related myocardial depression, no, that can lead into cardiac injury. Wall stress, pulmonary embolism, which we're going to discuss later, no, is also leading to cardiac injury. Trauma to heart, okay, it can be mechanical or cardioversion. can lead into what we call cardiac injury. Okay, those are those are conditions associated to what we call cardiac injury. Now, for cardiac marker for heart failures, now we have your, what do we mean by heart failure? When we said heart failure, this is a pathological state wherein the heart fails to supply metabolic needs of the body. And the primary reason of heart failure is due to decrease in the pumping function or pumping capability of the heart. That can lead into what we call congestive heart failure, okay, which is the most common cause of the heart failure. Bakit? Dahil na-congested yung heart because of the failure of the heart to pump the blood, na overload na yung volume. Okay? And congestive heart failure can also be due to transudates or effusions. Tinutubig yung puso in layman's term. There are tests to monitor cardiac or heart failure, such as your BNP or your B-type natriuretic peptide. B-type natriuretic peptide. And of course, your troponins as a cardiac marker. Like what I've said, we have what we call pulmonary embolism. This is a condition, no? This is a condition wherein meron nag-block like this, as you can see, no? Log in the pulmonary arteries impairing the blood flow. Okay? Kaya, di ba minsan you heard, meron nagbara sa may binti niya, hindi nagkadalo yung dugo, kaya siya inatake sa puso. That is what we call pulmonary embolism. Embolus. This is what we call embolus. Log in the pulmonary artery, no, that can lead into the impairment of the blood flow. Remember that diagnosis can be challenging. Why? Because it is almost similar with other conditions such as acute coronary syndrome. Pulmonary embolism sometimes or often have no signs and symptoms. And the classical representation of this pulmonary embolism includes dyspnea, tachycardia, tachypnea, and coughing, which is almost similar to ACS. In order for us to test the presence of this condition, we have what we call D-dimer testing. Okay, D-dimer. I know that you heard it in um, hematology. D-dimer is a product of plasmin-mediated fibrin degradation. Remember, guys, that the presence of the D-dimer in the bloodstream is indicative of recent or current coagulation and fibrolysis. Okay, and there's also a possible test or the possible use of troponins and pro-BNP or BNP test for pulmonary embolism. Thank you very much, and I hope you learned. Mabuhay ang mga medtech student na patuloy na lumalaban sa kabila ng hirap na lang naranasan. Stay safe, everyone.